nodes in the center of the chest, the mediastinum, is critically important before proceeding to lung cancer surgery. And historically and traditionally, this has been achieved by means of surgical techniques such as a cervical mediastinoscopy, which is widely practiced in many centers throughout the world. In more recent years, new endoscopic approaches, endobronchial and endoscopic ultrasound, have been trialed to see if they are as good as or better than the standard surgical procedures. And we've recently undertaken a randomized controlled study called the ASTER study in 3 European countries, Belgium, the Netherlands and the UK. We randomized 241 patients to either having endoscopic staging or to having surgical staging on a one-to-one basis. And essentially what we showed at the end of the study is that the patients who initially had an endoscopic approach using EBUS in the US and only had surgical staging if the EBUS in the US failed to show malignancy, actually had a better sensitivity for detecting nodal disease in the mediastinum than patients having surgery alone, and that was 94% versus 79%, which was statistically significant. So we believe, based on data which we've presented at this meeting, looking at the quality of life and the cost effectiveness, which has shown that actually patients having the endoscopic approaches seem to prefer it, the quality of life scores were higher, and also cost effectiveness, it seems to be cheaper than the surgical approach. We believe that taking the clinical data and the quality of life and cost effectiveness data together, that patients should start off their investigations having the endoscopic approaches and using surgery only as a backup if the endoscopic approaches don't show any evidence of malignancy. And we think this is the new way forward, and that this work probably will change practice globally. Not all patients actually have cancer in their mediastinal nodes. So that's to do with the prevalence. So if your prevalence, let's say, is 90%, so let's say they have a cohort of patients where 90% of them actually do have cancer in their mediastinal nodes, we know that the EBUS and EUS will actually show that cancer in about 90% of instances. If, however, your prevalence is about 50%, and actually that is generally about the prevalence, if you take a group of patients who've got lung cancer heading towards potential surgery, many studies have shown that the prevalence is around about 50-55%. That means that in the 50-55%, the endoscopic approaches will show the malignancies there. What we're doing for the other 50% is actually double checking that they truly haven't got malignancy by using the surgical approach before going on to a thoracotomy, which is a big and invasive operation, and you don't want to be performing those operations in patients who have got cancer. But actually we're now showing that the endoscopic techniques are really, really good at even picking out the patients who haven't got cancer. So the so-called negative predictive value is actually very high as well. And that does now beg the question in the future, if you've had an EBUS and EUS and it's negative for malignancy, do you actually need to have that surgical double check before going on to thoracotomy, or can you actually miss out that step and just go straight ahead? And that debate is now being hotly discussed among clinicians.